Hi, it's Andrew Weickhardt here, and it's fantastic to have you, Tom, to discuss the updates in bladder and kidney cancer that you've been covering for us at ANZUP. And I'll introduce you. Most of you listening to this talk will be familiar with Tom, the head of GU Oncology at St. Bart's and a well-known figure in GU Oncology and fantastic podcaster as well. So much to talk about, Tom. Let's just thinking about kidney cancer. There's a lot of data that's come out in the last 3 years. How are you putting that data into practice?
And I think that it's really changed practice a lot. It's been just a seismic change. Before we had algorithms of first line, second line, third line therapy, and it was all based around sequencing drugs. We now have what I describe as pretty powerful first line therapy with more toxicity than before and more difficult to give, better drugs, more difficult to give. But we then also have really complicated algorithms. What do we use next? We don't really know. We still haven't solved, let's talk about biomarkers in a second. We still haven't solved the issue about whether or not, everyone gets good, intermediate and poor, get Axi Pembro or Cabo Nivo, Ipi Nivo, intermediate and poor. How do you choose between them? I don't think that's the most important issue. As I said in my talk, the most important issue is around being good at giving one of the regimes, because from a survival perspective, they look about the same. But I don't think they're the easiest regimes to give. When you go under toxicity, is it one drug, is it the other? Do you give both? You stop both? You start steroids? These issues are practical issues. I don't think we're talking about enough. We're talking a great deal about should you give Ipi Nivo, should you give Axi Pembro. We're not really talking enough about, do you need to go beyond 2 years? Do you need, how do you deal with grade 3 toxicity? What's the patient's experience like? So I think there is currently, we got into a discussion about pazopanib and sunitinib a few years ago. You and I were involved in that, which I enjoyed. That discussion has now been parked, and it wasn't super exciting. There were more similarities and differences between them. This discussion, I think, is much more different. And the other thing that's important is we're beginning to see some biomarkers which are differentiating between them, but we're not using those biomarkers. And the biomarker program, I think, is important. I think there are patients who do definitely need upfront VEGF targeted therapy, but not everyone. And I also think there are some patients who will get long-term benefits from CTLA-4 inhibition, but I don't think it's everyone. And I suspect there are some patients that can get monotherapy nivolumab or pembrolizumab, but it's certainly not all of them. And we seem to have made almost no effort to identify those. Instead, what we do is we bar one drug on top of the other, and we're giving quadruplets and triplets. And I'm not sure that's the right answer. So I just think it's a really interesting time. And Andrew, the bit that's exciting is the investigator community like you and I and everyone else in the room listening to this, rather than the pharmaceutical industry, now has a big role. They have handed us these fantastic tools to use. We now need to work out the best way of using them. They will continue to develop drugs, but we as an academic community need to refine some of the things. We certainly need to make an effort to try and work out in whom we should be giving the combinations to. The IMDC classifications based on hemoglobin, on nephrectomy, on these parameters which have got nothing to do with biomarkers. Why aren't we looking at biomarkers in more detail?
Yeah, it's such a challenging area, and you've been involved in a lot of biomarker research. Do you think anything is ready for prime time for people in the clinic tomorrow? Can we test for PD-L1 and think that, if you're PD-L1 high, CTLA-4 inhibition should be a preferential first line inclusion, or is there an RNA angiogenesis signature?
I did a podcast with a chap called Bill Kalin who won a Nobel Prize, and
I like that. That was a good one.
But and I wasn't trying to. I'm not a huge self-publicist, or I'm trying not to be. I might be. I don't know. But the reason I mention it is our debate was, he was saying actually in kidney cancer, it's a one size fits all. The method of development of the disease is quite similar, and we just need to find better drugs. And what I was trying to argue was actually we've reached a bit of a plateau in terms of drugs we have in front of us now. And we probably now need to work out who benefits from what, because we do know that Mrs. Jones, who I'm going to see in clinic this afternoon with Ipi Nivo, has got progression of disease on cycle number 2, and she's sitting next to Mr. Smith, who's on cycle 37, who's going fine.
Yeah.
So why don't we make a bigger effort to work out what's going on in Mrs. Jones's tumour? And why don't we work out if we should have given her axi-pembro instead? Why don't we do that? Are we nearly there? Well, actually, just PD-L1 TC expression has got a hazard ratio of 0.45, whereas in the ITT population, it's 0.63, and in the biomarker negative population, that bounces up to low 0.7. That's something we can do immediately. You know, PD-L1 positive, axi-pembro versus ipi-nivo.
Yeah.
Bing. Off. We're off. We've got something to start. We just choose not to do this. Now, there is some terrific data on RNA signatures, which is kicking around. There was some beautiful work in Cancer Cell recently that Bob Motzer led from the 151 Bevatezo program, molecular classification, 6 different tumor types with 3 key types: immune type, for me, angiogenic type, and there's also this cell cycle type, this group that does badly. And those groups, I guess that they include the sarcomatoid groups. And I think, again, sarcomatoid renal cancer, ipi-nivo versus axi-pembro, not a bad study.
Be very interesting. So new drugs in kidney cancer, the HIF2 inhibitors are obviously pretty sexy and interesting. How do you see us using them in patients in the future? Do you think they'll combine well with other drugs or be single agent first line drugs for some patients?
So this is going to be, for me, it's a combination drug. I know there's a single agent randomized phase 3 study, but that will be about getting EMA and FDA approval. Once you have approval, it's much easier to develop drugs. It's very hard to develop drugs without an approval. So that's an attempt to beat everolimus, which I think is a relevant first step, but it is almost a stepping stone towards combination therapies and incorporation into the frontline space, and whether or not you can use it as VEGF sparing, but it won't be a monotherapy. So ipi-nivo, HIF, axi, HIF, pembro, those kind of regimes I can see being developed. I don't know they're going to be developed, but I can see that from the back of the room, you'd want to be developing. Is there a role second line? Yeah, I guess so. So, again, there's this debate ongoing. We just seen lavatinib everolimus press release. We've seen lavatinib pembro data. We know that Merck now owns lavatinib, and it does have pembro, and it also has HIF, and so you can see those coming together under one umbrella in terms of drug development. But do I see the CR rate going up to 30 or 40%? No, I don't. Do I see the CR rate in subsets going to 30 or 40% with triplets and quadruplets? Maybe. But I don't think the drugs we have in front of us are going to cure most. I know it's ambitious, but the drugs we have in front of us, I don't think any combination of permutation is going to cure most patients. In fact, I don't think the CR rate of triplet therapy is going to go up to 25%, maybe 20. Wouldn't that be terrific? But it's still not enough. And then the question is, where is the next group of drugs coming from? And actually, we're not talking in the meetings. Yes, there's arginase and there's other bits and pieces, but we're not talking about, the next big immune therapy, VEGF therapy, the next big breakthrough. And so I think we may have a bit of a pause for that. And therefore, we need to refine what we have. And during that period, patient selection is going to be important.
Yeah, so many interesting things we could talk on about kidney cancer, but we wanted to touch on the bladder cancer topics that you raised. And, so much interesting data presented in the last 12 months. Let's start with maintenance immunotherapy and why that approach seems to be a favorable one for our patients now rather than first-line combination immunotherapy chemo.
So I think actually it's quite straightforward. Second-line immune therapy, by that time, many patients don't get second-line therapy and the cancer is growing fast. And so it's too late for most. Mm-hmm. We now know frontline immune therapy, the response rate isn't high enough to get in control of disease, and the biomarker doesn't work well enough to select patients. And therefore, giving chemotherapy first and getting in control of the disease, and once you're in control, that maintenance period has bought enough time for the immune therapy to work in many. And it's actually quite straightforward. I don't think there's too much, some people talk about neoantigen release, others talk about ADDC with avelumab. I don't think that's the answer. I think the answer is strategically that's the right approach. one of the things that was surprising was there was not synergy or additivity between chemotherapy and immune therapy. And if you could take me back 2 years, and you and I sat in many rooms where I said, I think they're going to be additive, as was the case in lung cancer. We don't know why that's the case in bladder cancer, but it looks pretty compelling that giving chemotherapy and immune therapy together is not the preferred approach. And it looks like sequencing these drugs is easier. We need to do some work as to why that's the case. We know that the biomarker signatures of bladder cancer is different. The TMB is high, the PD-L1 is high, but it has a very high stromal component. And whether or not that's relevant, I don't know.
Yeah, it's very interesting, the data with the first line trials, the duration of response in the combination arms for patients that were responding seemed strikingly less for patients that had chemotherapy with immunotherapy as compared to patients that got immunotherapy alone. Do you think there could be a negative interaction with chemotherapy in bladder cancer with the immunotherapy?
You know, I think the question you've asked is an important one. And the initial indicators are that that might be the case. There does seem to be some blunting. And, you know, as you say, even in the ones that should work well with immune therapy, they're not doing that well. And why is that?
Yeah,
I think you're right. I think we need to do a little bit more work on it. As it currently stands, it looks like enfortumab vedotin is coming into this space and retesting the same question, but we hope with a different answer.
Yeah, the antibody drug conjugates sound really intriguing, and obviously the data is just incredibly sort of active in the combination with pembrolizumab, with the enfortumab. There's some data at ESMO as well on other targets with antibody drug conjugates. Where do you think ultimately we'll sit with those? Do you think it'll be in the first line with combination immunotherapy, or will it be salvage?
No, I think these drugs will come right at the front, and I think they'll go into neoadjuvant setting as well. And I think antibody drug conjugates are here. The question that's unanswered at the moment, if it does turn out to be an excellent partner with immune therapy, I think it will change everything. Because at the moment, one of the trials I'm trying to do, actually, and I'd love you guys to try and get involved if we could, I'm going to try and give 3 versus 6 cycles of chemotherapy followed by maintenance of avelumab. Again, coming back to the principle, it's an investigator-initiated approach.
Yeah.
But the question is, because most patients don't want to have 6 cycles of chemo.
Agreed.
If chemotherapy inhibits the effect of immune therapy, you're better off cropping the chemotherapy and then getting the immune therapy. And 3 cycles is probably enough to get in control of disease.
Yes.
Because 6 cycles of chemo is quite a long period of time. And if you can give a cropping period, short period of chemo, get the immune therapy in, and then maybe give the antibody drug conjugates after that, that would be an attractive approach. But 6 cycles of chemotherapy followed by avelumab, I think if EV plus pembro is positive, it will supersede chemotherapy followed by maintenance of avelumab in those countries that can afford it.
Yeah, it's another expensive drug to hopefully add to the armamentarium of us treating bladder cancer if those trials are positive. The other drug, which is intriguing, and I think you've got some experience in this involved in the trial, is, are CTLA-4 inhibitors going to have a role in treating bladder cancer? And obviously there's a signal from the phase 2 studies in advanced metastatic second line setting of ipi-nivo, but you presented some data as well in the first line. How do you see that?
Yeah, that was the most frustrating slide of my life, because I did actually want it to be a biomarker positive both arm trial, and I really kind of, I got a lot of things wrong in my career, but that's one of the things that I really pushed and would have been right on. I think the ipi-nivo trial in that setting will be positive. I think CTLA-4 adds response rates about 10% to baseline PD-L1, and that's enough just to get the combination over the line, if you know what I mean.
Yeah.
I don't think it works particularly well in the biomarker positive groups. I think it's just a bit better in both, and it happens that if you enrich a little bit, you push it over the line. I think this time next year in the United States, ipi-3 nivo will be a standard of care.
Yeah, it's going to be
in biomarker positives.
It'll be intriguing to see how those trials play out. But you've talked with us and generous in your time today, both presenting the data and catching up and talking about these developments. So thanks so much, Tom, for joining us. And we look forward to
Thank you for inviting me. I'm going to come. If I'm invited, which I've been invited before, but I would really love to come out.
It would be
so
brilliant.
I'd love that. Listen, I hope we're going to see you soon. It's only a matter of time.
Perfect. See you, Tom.
Lovely. Thank you very much indeed.